It might be a friend, a loved one, a coworker, or maybe it's you.
At least 30 million Americans are suffering from an eating disorder, a type of mental illness that left untreated can cause life-threatening mental and physical problems.
An eating disorder like anorexia, bulimia, or binge eating is one of the deadliest mental illnesses in the United States.
Nearly every hour in the U.S., someone dies due to complications related to an eating disorder.
But there is hope. Recovery is possible.
ANAD is here to help.
ANAD is a leading nonprofit in the U.S. that provides free peer support for anyone struggling with an eating disorder, regardless of age, race, gender identity, sexual orientation, or background.
Our nationwide network of volunteers understand firsthand the ups and downs of the recovery journey.
Because they too have lived the experience of an eating disorder.
ANAD empowers volunteers to help others through their own recovery.
Learn more at anad.org.
If you or someone you love is struggling with mental health or addiction, know that there is hope. Rogers Behavioral Health can help you find a path to recovery with highly specialized, compassionate care. A virtual treatment option is also available through Rogers Connect Care. Reach out today, and together we can not only face your challenges, we can rise above them.
Hi, everyone. Welcome to ANAD's virtual conference, our 2020 webinar series. This is the second webinar in our series. We're hosting these all throughout October on Wednesdays. So welcome to today's webinar. We're really excited to be talking with Brad Smith today. But first, I'll give a shout out to our sponsors. Next slide, please. So thank you very much to our webinar series lead sponsor, Rogers Behavioral Health, as well as all the other sponsors you see here on the screen and our great exhibitors. Be sure to check them all out at our website. You can learn more about each of these treatment centers. And we are so grateful for their support throughout this webinar series. Some housekeeping items. During the webinar, you are welcome to type your questions either in the chat box or the question box throughout the presentation. I will be going through those questions, and then I'll moderate a Q&A session at the end of this presentation. And then at that point, we'll transition into the post-webinar small group discussion. And there will be a link for that Zoom meeting towards the end of this webinar, and you'll be able to just click on that link and head straight into the discussion. That'll be a nice chance for you to actually see some of the other people in this webinar and interact with some treatment center representatives from our sponsors. After the webinar, you'll receive 2 emails. This afternoon, you'll get the recording of this webinar. And then tomorrow you'll receive the webinar evaluation. The email address is listed here, so check your spam in case you don't get it tomorrow. And then in a couple weeks, you'll get your CE certificate if you have opted into that option. So now I will go ahead and introduce our speaker today. He is going to tell us about treating men with eating disorders, and we're really excited for him to share with us some insight and perspective on treating this subset of the eating disorder population. He is a Brad Smith is a full-time psychiatrist and serves as the medical director for Rogers Oconomowoc campus, as well as the medical director of eating disorder recovery. He is board certified in adult psychiatry and forensic psychiatry, specializing in the assessment and treatment of eating disorders and other complex or multiple mental health diagnoses. Dr. Smith joined Rogers in 2011, seeing patients in the inpatient, residential, partial hospitalization, and intensive outpatient programs, helping patients learn evidence-based techniques for building resilience for recovery. In addition to his leadership roles at Rogers, Dr. Smith serves as a voluntary assistant clinical professor in the Medical College of Wisconsin Psychiatry and Behavioral Medicine Department, where he teaches residents and fellows. Dr. Smith received his medical degree at the University of Wisconsin and graduated from Washington University in St. Louis. So Brad, we are delighted to have you here today. By the way, I don't know if I introduced myself. I'm Lynn Slosky, the Executive Director. I'm going to now pop out and turn things over to Brad, and I'll be back in for the Q&A. So Brad, thank you so much for being with us today, and you can take it away.
Thanks very much, Lynn. It's really a pleasure to be here today, so thank you for the invitation. Like most of you, I wish we could all be together in more of our typical format of getting together, but I'm thankful for the technology and the tools that we have available to stay connected and do some of the things that we like to do in terms of continuing education. And my topic today is going to be a guide to the guys treating men with eating disorders. And I can't promise all that you'll take away from the presentation today or guarantee anything, but in terms of the afternoon, what I do hope to promise you is that I will not talk about the pandemic any more than just what I mentioned about us getting together via video rather than in person. And I promise not to talk about the election. So an hour and a half of time not spending any attention on those two topics probably is going to make for a pretty painless continuing education experience. So my task now is to start sharing my screen. So let's give it a try here. And then we'll go into the slideshow format. All right, so what we'll do today is we'll be going over a review of eating disorders in males, and we'll look at prevalence rates, some of the unique features for men with eating disorders, some important treatment considerations, and then just a qualifier that most of the work done in this field so far has been related to cisgender males. So that will be the primary focus of some of the research and the findings that we have in this subset up to date. And whereas a lot of the information about prevalence rates and unique features have been related to that, the treatment for males with eating disorders that we'll go over are techniques that are not specific to men, so they can be used with anyone. We use them for everyone. But my suggestion today, and including it in this presentation, is that these forms of treatment have seemed to resonate with men, especially for individuals who've had a little bit more difficulty engaging in more traditional talk-based psychotherapies. And so we'll be talking about exposure-based therapy and behavioral activation. And then we'll look at some of the treatment outcomes because we want to know if these techniques work, and we'll give some examples of that and some of the findings that we've seen in our setting. If we have time, we'll go through some case examples also, and I'll probably be able to sprinkle in a little bit of that as we go. I also want to give a thanks to my friend and colleague, Nicholas Farrell, who's the clinical director of the eating disorder program here at Rogers, where I'm the medical director. He and I have worked together for a number of years and have spent time putting this sort of presentation together, where we've given this together, we've tag teamed it, and we've given it independently too. So big shout out to Dr. Farrell for helping with this. So let's first look at some of the basic statistics that we have for this. For men with eating disorders, we typically see that lifetime prevalence rates are on the order for anorexia nervosa about 0.2 to 0.3%. Bulimia, we're at 0.1 to 0.5% lifetime prevalence. Binge eating disorder is a bit higher, 1.1 to 3.1%. And it's commonly seen in studies that about 25% of individuals with anorexia or bulimia are males. When we look at binge eating disorder, however, we have a low end of about 36% in most studies, all the way up to some studies with 50% of the individuals with binge eating disorder are males. We're early on in our understanding of ARFID, but there doesn't seem to be a major gender difference there. And then another estimate here is that 10 million men in the United States will experience an eating disorder. So it's not a rare phenomenon, but again, we're looking at this from the standpoint of a subset of individuals who had early on in the field had felt a bit of a fish out of water when entering treatment for this illness. The prevalence of eating disorders more than doubles from about age 12 to 20, so the typical time frame for this becoming a problem is fairly similar to women. So what are some of the unique features that we find in males related to the eating disorder population? There's limited research comparing males to females in this, but when we do look at the comparisons, it seems that most of the features of eating disorders turn out to be more severe, at least in our current way of assessing. So some of our current outcome measure, our questionnaires, our clinical criteria seem to capture the symptoms related to how females have experienced these illnesses. And so we see things like body image dissatisfaction, dietary restraint, purging, preoccupation with thinness, all being coming out as more severe in females when we do the comparisons. But a few of the features seem to be more severe in males, and predominantly the preoccupation with muscularity in comparison to the drive for thinness we might see in women. And also the excessive exercise, which of course can happen for anyone with an eating disorder, but it's something that stands out a bit more in the male population. In a relatively recent study that included some of the work of individuals who have here at Rogers and then colleagues elsewhere had looked at some of the estimates of how our current questionnaires related to outcome measures such as the Eating Disorders Examination Questionnaire and the Eating Disorders Inventory 3, how those compared of males versus females. And this is one of those studies that showed what we talked about just above, that nearly all of the eating disorder features seem to be assessed as being significantly higher in females, but there was some evidence of exercise and binge eating being more common in the males, or more severe in males. So one of the first places to start for males with eating disorders is the body image differences. And there tends to be more of a desire for an athletic or muscular physique, a V-shaped torso, a variety of descriptors for this type of physique, versus the thin ideal that is typically sought after for individuals with anorexia nervosa who have idealized that thin appearance. You know, we see in all populations that the media depictions of what the ideal physical state is tends to influence what people strive for. And, you know, if those techniques didn't work, they would not be used. We would not have people in marketing or commercials, advertising. These techniques work, and so it seems to be no surprise that they're a factor in individuals with eating disorders. They certainly don't seem to be the entire factor, but they do drive a lot of the opinion of individuals as to what their body should look like. So among men who are having troubles with eating disorder symptoms or behaviors, the body image dissatisfaction tends to be more towards wanting a more muscular appearance. In fact, most adolescent males who exercise report that it's to bulk up, even those without an eating disorder. So it's usually a different reason for engaging in exercise. Included in this is the concept of muscle dysmorphia, or the term has been given bigorexia, where it's an attempt for males or other individuals to try to get their muscles to a bigger shape, and then having the distortion that whatever they do, their muscles aren't large enough or aren't defined enough. When we look at the co-occurring psychological issues in males, they don't look that much different from the female populations that have been studied prior. There's a high comorbidity of mental health issues for individuals with eating disorders. And the comorbidity patterns seem to be pretty similar for males and females. There's some evidence of increased depression with males, and perhaps that's one of the reasons why the mortality risk seems to be at least a bit higher among males. So when we think about some of the common considerations, we first are looking at some considerations among males with eating disorders that it tends to be less emphasis on thinness, more on muscularity. So the body image issues, the distortions, are a bit different. There are exceptions to the rule, certainly, but this is indicating that there's more emphasis on the muscularity among men than we see among women. There's a heightened prevalence of extreme exercise and binge eating among men, and then there's extensive comorbidity. Again, that's no surprise. We see that in all populations. The other factor that seems to be sometimes underemphasized is the stigma that comes with an eating disorder for a man. So these have traditionally been thought of as female disorders, which leads to some stigma for men who are trying to come forward with having symptoms or behaviors. And it causes problems in, first of all, recognizing eating disorders, also in acceptance of eating disorders among individuals who have them. And then it also can affect the treatment available. So one of the concerns here is that the very assessment instruments we're used to using seem to underestimate the severity of the illness. Some of the instruments that we commonly use have been geared more towards the symptoms and behaviors experienced by females, and that ends up meaning that males could have pretty significant pathology without looking as severe on our usual instruments of study. The other factor I think that is important to consider is that many people enter eating disorder treatment because of physical consequences or medical complications that occur because of their eating disorder. Common scenarios for people being referred for eating disorder treatment are things such as laboratory abnormalities, extreme changes in weight, typically a significant drop in weight, perhaps a cachectic appearance, changes in vitals, heart rate abnormalities. These are things that often bring someone from a primary care setting or general health setting into an assessment and treatment for their eating disorder. When you look at how the eating disorders tend to develop for males, if the ideal body image and what they're striving for is more muscularity and not so much the extreme thinness, then some of those factors, those early warning signs, really aren't there as prevalently in the early stages. We don't tend to see them being picked up by their primary care clinician because of extreme weight loss, because their weight number may not change that much. It might even go up. But what's missed is the appreciation of the level of obsessiveness that has started to occur regarding their dietary restraint, their extreme exercise, and the preoccupation, obsessiveness that has been developing related to trying to get to a level of perfection with this ideal body state. So it's my belief that we miss a lot of the opportunities to get people referred for treatment because some of the physical health issues that we're typically looking for just aren't happening quite yet. And as we all know, it's an ongoing struggle to improve our understanding of and recognition of eating disorder symptoms and behaviors so that people can get referred to treatment as early as possible. And so some of these physical health changes are often the very reason that people get referred on for eating disorder treatment. And for men and young men and boys, they may not have that same development where these laboratory changes, the weight changes may happen earlier for someone with this drive for thinness versus someone who's more looking for muscularity. The other factor, of course, is the stigma, and this can be a very significant barrier for people engaging in treatment. So a gender-sensitive approach is important, and I think, if we look at the evolution of this, we first started with our field as being a field mostly centered around the understanding of these disorders as it relates to women. Then we started adding in some better realization of how they are understood and treated for men. And then we're expanding our understanding, our appreciation for everyone, whatever gender, whatever sexual orientation. So I think that whole move of all of us trying to become more sensitive and inclusive of our treatment environments and our treatment approaches is obviously going to help then with any subpopulation. And so for the men seeking treatment in eating disorder treatment centers, that gender sensitive approach is probably much better now than it was 10 or 15 years ago. But it's still important to keep in mind some of these unique differences or challenges that may be part of the approach. There has been a suggestion that a completely separate environment for males may be ideal. And I think that was probably very true many years ago. And I think back to the treatment environments being much more centered around treatment of women and girls, and that trying to move towards more inclusivity of men with eating disorders was part of the evolution of our field. And that early on, it probably was very important to make sure that the environment was conducive for males with treatment needs. I'll acknowledge, though, even though Rogers was one of the places that had one of those exclusive male treatment environments and promoted that, we have since gone away from that to try to have a much more inclusive environment for everyone and try to really individualize this gender sensitive approach for the men in our program. We are lucky enough to have a wealth of experience, a collective experience of working with men with eating disorders so that we can bring that to the table. But as you'll learn as we go forward here in the treatment approaches, a lot of what we try to get away from is the idea of someone needing to avoid things that make them anxious. And so having a more inclusive treatment environment has been an important part of that, to make sure we're not adding to the avoidance that some people may have, while continuing to make sure that it's comfortable and feels welcoming for everyone in the program. And for today's topic, that has been for the males in the program. And the other concept here is that men may need to be engaged differerly than females when it comes to treatment approaches. So I will qualify this, that most of these comments here are based on my anecdotal experience of working with a large number of men and boys with eating disorders, and also for men and boys with different types of mental health issues, that the typical way of engaging in psychotherapy seems to pose some barriers for a lot of men and boys that are not used to talking about the feelings or relationships, and are especially not used to talking about it in a quiet room, sitting across from someone, establishing eye contact. That is, that's a very, I'll poke fun at my own male counterparts, that's a very evolved man that can do that. And not all of us are there. And so I think when we're looking at how to engage with individuals, and this part is for any individual we're trying to engage with, our typical techniques of sitting in a chair across from someone with good eye contact may work for a large number of people, but when it doesn't work or they're not engaged, what are the other methods that we can try? What are the other tools that we have? And that's what I'm referring to here, is that I find it more common among the males that we treat that those typical methods of sitting across from one another, talking about sensitive topics, at the expense of someone feeling very vulnerable, there tends to be more times among our males where we need to find another approach. So it is common for me to see our therapists working with men to be out at the basketball hoop playing a game of horse while then talking about something that they've been trying to work on in therapy, or grabbing a football, playing catch, sitting down at the game of checkers. But the concept here is that trying to break down the barriers of what's getting in the way of engaging, what's getting in the way of that relationship building, and trying to find a way for that rapport to be built. So I'm often reminded of some examples of how men typically engage. And for anybody on the webinar right now who's, I would say maybe 40 or older, probably recognizes this as a scene from When Harry Met Sally. It's a very popular movie for many years ago. I had many concepts related to relationships played out in this movie. And most of it was related to male and female relationships or couples. And yet there was also some demonstration of this friendship between Billy Crystal and Bruno Kirby of how males engage in discussion of relationships. So one of the scenes you see here is that they're at a batting cage, just doing some batting practice. And the scene evolves where they're having a very sensitive discussion about their relationships and also about their love life. And yet it's all happening while they're doing something. They're actively engaged in a sport. It kind of makes it more possible to have these discussions. There's another scene in the same movie where they're at a football game and they're having these in-depth discussions as the football game is going on, and they're literally taking part in the wave going on in the stadium as they're having these discussions. So that movie really resonated for me about how difficult it can sometimes be to engage men in typical forms of therapy, and that trying to find a way to break down some of the barriers, to have something based more on building it around an activity or somehow having something else going on may be a good way to bridge that gap. And you might then later get to a place where they can engage a little bit differently. This kind of goes to the rationale that when we look at how to look at different types of therapy that might be things that resonate with males, that's where I go to the behavioral therapy. So forms of cognitive behavior therapy, more specifically the behavioral therapy versions, that we may find men more willing to engage in this type of therapy where there's an aspect of doing as opposed to solely talking about it. Now, if you're being kind of an academic stickler about it, the CBT approach and using this behavioral therapy, what tends to happen in treatment environments like ours that use this approach, it's certainly not doing away with the more traditional forms of looking at cognitive distortions or looking at thoughts and feelings, but it's adding the behavior therapy component to it and trying to make sure we're really addressing those behavioral changes, because those are the parts that really take some time. They take methodical practice, and they're kind of labor intensive. I think all of us have the experience of, coming up with an epiphany or a breakthrough or just a change that we want to make in our lives. So we make a commitment to ourselves to do it. And that's not really the part that's going to get us there. The part that ends up really getting us there, that's the starting point, but the part that gets us there is the putting it into practice. And, a similar example, I think this type of approach resonates often with athletes and musicians. And I can say that I can tell somebody how to play piano. You take your finger and you press down on the keys, and that's how you play piano. But you have to put in the hours and hours of practice for it to sound like something that is beautiful and to make a change in how it sounds compared to the clunking that you did originally. And so with the CBT, with spending most of the time on the cognitive part and not much on the behavioral change part, we're missing the opportunity to have people really put these things into practice. And so these behavioral therapies are designed to really make sure people can put these things into practice and make the behavioral changes with a lot of support and assistance as they make these important changes. So another rationale for looking at behavior therapy as it relates to treatment with males is that avoidance plays a very significant role in the maintenance of eating disorders. And the behavioral therapy techniques that we'll talk about today, which will include exposure-based therapy and behavioral activation, both target avoidance. So that's one of the reasons why they lend themselves well to eating disorder treatment. Some eating disorder features that are seen at higher rates in males, such as binging and exercise, respond particularly well to this type of behavior therapy. These are behaviors that are very difficult to change unless somebody is doing a very methodical, assisted way of trying to put these behavioral changes into place. Another rationale here is that there's such a high comorbidity and symptom overlap, as we see in all populations. But if we're understanding that males also have anxiety and mood disorders along with the eating disorder, then it seems to make all the more sense to apply techniques that work for anxiety and mood disorders embedded into the treatment, and to try to apply some of those same techniques to the similar symptoms that are part of the eating disorder. And again, I'll go back to, these are therapy techniques that I'm suggesting might resonate with men when you're having trouble with the engagement, but they're not exclusive to using them with men. They are the same techniques that we tend to use with everyone. So let's look first at the first behavioral therapy technique I'll look at here is exposure-based therapy. So this is a known effective approach for addressing fear-based problems, many anxiety disorders, very typically obsessive compulsive disorder. It's the gold standard treatment for individuals with obsessive compulsive disorder. And it involves a gradual approach of fear-evoking situations rather than continued avoidance or safety behaviors. So that's kind of a mouthful, but what this means is, the adage of, something that's fear-inducing or that causes anxiety, rather than continuing to avoid it, we're going to walk through a process of trying to do those behaviors or put you in those situations that will provoke the anxiety, but we're going to do it gradually, and we're going to help you through it. And so we're going to not flood you with it. And that is very important, because if you flood people with too much of the anxiety-provoking situations right away, it can tend to backfire. But if we can build some of the trust and the rapport and help them through the early stages of this exposure-based therapy, they can make significant changes in their usual behaviors. So the foundations rest in the fact that the person's fear will dissipate within situations of doing the same thing over and over. And that also generalizes typically to other situations, as well as to any times in the future when the same scenario might present itself. Individuals learn that these feared outcomes, which are typically very catastrophic fears, are much less likely, and importantly, they're more tolerable than the person anticipated. So it gives them some confidence that they can move forward and address these situations as well as others that may come their way. So if we take a look at this as it relates to a situation that's not based in eating disorder treatment, we'll take a look at a common fear of dogs. So if someone has a core belief that dogs are violent, dangerous animals, what tends to happen is that they will have increased attention towards that sort of threat. So if any of us who are not afraid of dogs are walking down the street and we hear a dog barking, it's probably just like background noise to us. As someone who holds this belief, they're going to be on high alert that something is going on, something is to be feared here. So when they come in contact with the dog, there's going to be an automatic thought that the dog is going to bite me or cause damage. And the natural fear response will happen. What's important here is that the fear response is excessive compared to other individuals who do not have this core belief or fear. Heart rate increase, breathlessness, which typically avoids what in CBT terminology is called a safety behavior. Any behavior that someone does to try to neutralize the anxiety and not have to experience it. So in this situation, it could be walking to the other side of the street, could be deciding not to go walking in that neighborhood anymore, all of which strengthens that core fear. So some of the shared features of anxiety disorders are important to consider, and they were exemplified in that flow diagram, that it involves a core belief about a negative outcome. It results in some biased information processing where somebody has heightened attention towards whatever they're fearful of. So again, I'm going to be more on high alert when I hear a dog barking because I have that fear. There's going to be excessive anxiety compared to someone who does not have that fear. And then there's likely to be some sort of safety behaviors or some sort of compensatory behavior change that someone does to engage in avoidance. So what is this exposure-based therapy then? How do we look at that same situation in a treatment context? And the change that we would want to make here is that we would actually have the individual confront the feared stimuli, to actually start spending time with dogs, while simultaneously trying to eliminate these safety behaviors, which, you know, in the previous example were things like, we don't want them to walk to the other side of the road. We don't want them to avoid going for a walk in that neighborhood. And the confronting of the feared stimuli might start with something which could be expected to cause much less anxiety than a direct confrontation with a dog. It could be something like looking at pictures of a dog, then graduated to looking at a dog that is in a kennel, then moving up to, you know, being in direct contact with the dog. So the aims of this graduated exposure would be to reduce the fear and anxiety, to also try to disconfirm the beliefs about how bad the consequence would be, and then to continue to build this tolerance of distress. You know, similar to the adage from FDR, the only thing we have to fear is fear itself. We're trying to get people to not be afraid of the fear, that the tolerance of distress, if we can build that up, people won't be as fearful of just the very aspect of being anxious. This is a highly effective strategy for treating fear-based problems because of this. So social anxiety, OCD, even generalized anxiety. So anything that's based on a fear or simple phobia, it's very amenable to exposure-based therapy. It also has clinical applications in other areas, like for purposes of today, eating disorders, some characteristics of personality disorders, trauma-related problems. So it is growing in its application to other areas. Why do we think it works? Well, collectively, the field believes it works because it involves habituation. The concept that with each repetition of doing something that is anxiety provoking, we tend to experience that it's less anxiety provoking each successive time that we do it. We also have the concept of violation of expectancies, where the catastrophic fears that we thought were going to happen do not happen. And so that allows us to go back and do a bit of a reality check, as the sign says, which is, like some thought restructuring or thought challenging, like that expected outcome, that catastrophic outcome you thought was going to happen, didn't happen. So you might have a little less anxiety the next time you go into the same situation. And then finally, the third component of why it seems to work, or the hypothesis of why it works, is because of the self-efficacy. That this process involves having people learn to tolerate some anxiety, which gives them increased confidence they can tolerate distress in other situations too. So those three components seem to be the major reasons why this works. We look at how to apply this to eating disorders because there's so much overlap and similarities of eating disorders and anxiety-related problems. Similar to anxiety disorders, eating disorders share a lot of these similar features where there's unhealthy behaviors aimed at controlling something, preoccupation with food, weight, and shape. There's intense body image distress and low self-esteem across most of the eating disorder diagnoses. And then also there's this feared consequences of what happens when something is eaten. What happens if I don't engage in purging, or if I don't overexercise? So there are these feared consequences, which typically lead to some form of compensatory behavior that would help to reduce the anxiety. If I eat this meal that my dietitian has asked me to eat, then I need to compensate by running 6 miles. So trying to then remove those compensatory behaviors, because if they continue, they strengthen the original fears. So if we look at that similar flow chart and how it responds or how it relates to eating disorder treatment, we have a similar but different type of a fear here, that people will reject me unless I'm lean and muscular. So this could be a good example for a young man with an eating disorder. And that would likely lead to increased attention or overvaluation of the shape and what my body looks like. Now, if then the person is confronted with a harmless piece of cake, it's going to induce this thought that I'll get flabby and lose all my friends, or even simply just that I don't want that change in my body. I'm convinced it's going to make a major change. And the fear gets excessive, where there's not only these passing thoughts that, a lot of the population might have some thoughts that if I eat cake, what does that do to my overall diet or meal plan, or what does that do for me? But here, with this intense fear, we're going to have increased heart rate, breathlessness, and then most likely some sort of compensatory behavior, exercising, restricting, probably not eating the cake, maybe not eating the meal that was supposed to be before it, all strengthening that original fear. So when we look at how to apply this exposure-based technique to eating disorders, we're looking at this similar concept of confronting feared scenarios, but the feared scenarios are typically related to eating, weight, body image, and often binge eating issues. So we'll be looking at certain foods, eating related scenarios. And I find that, even if a treatment program or treatment setting doesn't call this exposure-based work, that individuals doing work on the dietary side of this. So the dietitians I know in our program, before we started employing this type of exposure work, were already doing this type of exposure work. They just didn't call it that, where it's starting with safe foods, manageable foods, and then gradually expanding into foods that could be tolerated until eventually there was more of a normalized approach to eating. And so we've moved into now doing it much more methodically and tracking it, as we'll see in just a minute. So the other things that we would approach through exposures would be scenarios that were related to body image issues, maybe certain clothing, whether or not to pass in front of a reflective surface, and then binge eating cues. And then simultaneously, we need to work on preventing the safety behaviors. Or in eating disorder terminology, we tend to think of these more as the compensatory behaviors. So we want to help people to stop the restraint, stop the exercising, stop the excessive body checking, and also to stop the rituals at mealtimes. And what's important about these prevention of safety behaviors is that it is presented in a way in which we're teaming with an individual against the eating disorder, so that it doesn't feel as much like a power struggle of a treatment program or clinicians trying to prevent a certain behavior, or where it's an us versus them type mentality, but it's joining forces against the eating disorder in the name of this type of therapy, that the cognitive behavior therapy is only going to work if we can eliminate the safety behaviors, even if you can only commit to it for a little while. We'll take a little bit at a time and see if we can get that commitment there. And it might require us to gradually fade these things out instead of a cessation right away. So the steps involved in this are rather detailed here in the PowerPoint. So I'll go through this section a little bit more quickly because it's here for you if you have the interest and desire to employ these types of techniques. But I'll just give the foreshadowing that I'll go through this a little bit faster in order for us to get through both this and the behavioral activation. So there's a functional assessment, that is really trying to, in a very detailed way, get at what makes the person anxious, what are the major consequences or catastrophes that are feared, and then what are the compensatory or eating disorder related behaviors that are done to try to minimize anxiety, and doing this in a very methodical way. These behavioral therapies, as most of us know, are not so difficult from a conceptual standpoint, but they're very methodical. They require time, and they require a lot of practice to make these changes. They also require a good rapport with an individual, because people are naturally going to be more willing to feel safe trying things that make them anxious if they feel like they have a good rapport with the clinicians helping them through this. So this is very methodical, going through each type of fear cue, and we have them listed here. It's going to be related to typically foods and eating scenarios, body image related issues, as well as internal stimuli, such as medical issues like fullness, hunger cues. And then we'll go methodically through what are the dire consequences that you're fearing, and really trying to get that in a detailed fashion and assessing the specific behaviors. So this becomes very individualized, and it's very cooperative, and it's very hands-on for the individual going through it. The individuals who go through this typically feel like they're much more involved in the process. So developing the exposure hierarchy is the next step. So we literally create a list of all of the different types of feared scenarios that a person wants or needs to try to address to get to a better spot with their eating disorder. And this will involve, the various foods that they think they need to try or introduce into their range of foods. It will involve body image exposures. If they have binge behaviors, it'll be binge cues. But it's a very extensive list that's developed, and then it becomes the roadmap for their individualized treatment. So here's a simple example of a hierarchy for the purposes of demonstration of somebody who had a fear of eating dessert foods and also a fear of wearing form-fitting clothes. There are different ways of rating anxiety. Many places use the 0 to 100 scale, which is the subjective units of distress scale. Rogers, for whatever reason, many years ago, started with the 0 to 7 scale. So I'm accustomed to the 0 to 7 scale now. But we have people, in addition to writing down the things they need to work on, it's how much anxiety will that cause for the person. And this is a simple example here where trying on a bathing suit alone in a bedroom causes a mild amount of anxiety rated as a 1. And it goes all the way up to going out for ice cream with friends, which has components of the fears related to the specific food of ice cream, the fears of not being able to portion your own ice cream, to being with friends where there would be likely some judgment going on, some observation of what is happening, and then any social anxiety built in there just from that aspect. So that would be rated a 7, and you see everything in between. A very simple example of a hierarchy, as I want to make sure that you're aware that the hierarchies that are created are typically not this simple. It's usually somewhere between 50 and 200 items is kind of the average of how many things people will identify that they need to work on. Most of which will be related to exposures. Some might be related to behavioral activation areas that we'll describe in a few minutes. But again, a simple example here, seen with someone with some different fears, the fears of others seeing their stomach and the fears of binge cues. So their exposure list looks very different. There might be some overlap with the previous example, but most of it is individualized. And this gets back to the concept of this is a technique that can be very collaborative, and it actually by nature has to be collaborative because the individual is trying to identify exactly what it is that they've struggled with and that they fear they'll struggle with. And there will be some overlap or some common themes, but it ends up being very individualized. Next, we have to look at trying to find ways of eliminating those compensatory behaviors or safety behaviors. And it might involve a fading process or trying to reduce, but most of the time we look at trying to eliminate the behaviors. And certainly prioritizing the high-risk behaviors like vomiting and laxative abuse, things that could be have immediate medical consequences. And a lot of times our treatment environments can help with that quite a bit, because as we all know, the treatment environments like inpatient units or residential programs have a lot of structure built in to try to help people be more accountable and to not give in to these behaviors. But when we look at other less high-risk behaviors that we need to change or help the person change, we might start with having them do some daily monitoring to track their progress, not only to help emphasize for them, it's usually quite a shock how much time of the day they're spending on these behaviors, and then to be able to track how it decreases over their time in the treatment. And what's very helpful about this is that typically as people start to decrease the behaviors, their urges to use the behaviors tend to decrease as well, which is a little bit counterintuitive. And so it's a pleasant surprise as individuals go through this. And how is it best explained to individuals? Well, we need buy-in, quite frankly. You know, we need the buy-in that these safety behaviors or these eating disorder behaviors need to be eliminated, not because of a power struggle in the treatment setting, but because that's part of the treatment of how this exposure-based treatment works, is that if we have these compensatory behaviors occurring, then the habituation is not allowed to happen, and the tolerance really isn't allowed to happen, because the person is really just continuing the same, the same sort of safety behaviors they were doing before they came in. So sometimes that change of perspective of why we're trying to eliminate the safety or compensatory behaviors is helpful for an individual to give them up. And then conducting and coaching the exposures. We always try to start with something that's challenging but manageable. And then we want people to continue an exposure until it reduces by at least 50%. And so if something is starting out as rated as a 4, we want them to stay with it until it goes down to a 2. And then we want these to be repeated. Typically it takes multiple repetitions for them to get to a point where it's really producing minimal anxiety. And what do our clinicians do during this time? We're offering praise, encouragement, being cheerleaders. Again, having that good rapport really goes a long way for helping people to get over the hump to be able to do these exposures. We hold their attention on the situation and ask them to be mindful, because we don't want to substitute their previous compensatory behaviors with some new safety behavior unintentionally. So we don't have them employ a lot of distraction techniques or other sort of anxiety reduction techniques, unless we need to do it as a stepping stone to get to a point where they can be mindful and experience the anxiety so that they can experience that they can tolerate it. And then we're discouraging the use of safety behaviors. We're also constantly going over how they're doing with the situation and the exposure, checking in on levels of anxiety so we can keep rating it, and also checking in on how they're tolerating it. We then try to make our way through that hierarchy. So we will literally want to cross off items off of that list, and we usually use a measure that when people are rating the exposure as a 1 or a 2, that's one way it could be crossed off. It might also be crossed off if somebody endorses the ability to tolerate the anxiety, even if they might rate it a little bit higher than a 1 or 2. If they feel like they can tolerate it and they're ready to move on to the next exposure, then we move forward. The goal being to complete all of the exposures with maximal elimination of the safety behaviors. And as a rule of thumb, most of the time in these highly structured treatment settings, people are not going to get all the way through these activities, the exposures on the hierarchy, but there might be maybe a quarter to a third of them that they'll finish up with their outpatient treatment, because by that point, getting 70%, 75% of the way through this hierarchy, they're probably at a stage where they really can be more self-reliant and accountable to do all of the exposure work a little bit more independently. So the next behavioral therapy technique I'll talk about is behavioral activation. And as we go through these, I just want to emphasize again that these aren't specific for men, but I encourage you to think about how it might be, included in approaches for men who might have been struggling with engaging in other forms of treatment. So behavioral activation is a component of cognitive behavior therapy that is a very effective approach for depression. And the goal here is really to increase return of life activities that are meaningful and fulfilling. These are the very things that tend to go by the wayside when someone gets significantly depressed. We want to try to add them back in a way that's manageable for someone. So the foundations of this are that depression is at least maintained because of avoidance of important life activities. It may not be the cause of the depression, but it tends to maintain or worsen the depression if someone continues to avoid pleasurable activities, if they continue to avoid activities of daily living, it tends to compound the depression. So when we reintroduce fulfilling behaviors on a consistent basis, it usually helps to improve the mood and well-being, usually in conjunction with other forms of treatment for depression, but it's a very effective and methodical way of trying to build back in activation. So the model that's used for this is called the track model, where the triggers for what might lead to depression or more depression symptoms is that stressful life events happen, there's a painful emotional response, and then avoidance patterns set in where people have the typical types of avoidance of trying to isolate, not engage in activities, which is in contrast to trying to employ a really active coping technique. So when we look at a real life example, let's say someone didn't get promoted at work, that could be a trigger for depressing thoughts and feelings, sadness, fatigue, loss of interest. If they're stuck in this depression mode, or where they might maintain their depression, would be if they started calling in sick or arriving late to work. You can imagine that they won't get the next promotion at work either. If instead we can work with them to meet with their boss, go over some of their strengths and weaknesses, why they might not have gotten the promotion, what they would need to do to be eligible for the next available opportunity, those are the types of things that would be more likely to lead them out of depression and not lead to an exacerbation of the depression. So this is similar to how we involve people in gradually increasing their engagement in life activities again, preventing avoidance and other unhelpful coping techniques. And there are three main areas that are important to try to reintroduce. One is routine behaviors, which are important, behaviors not necessarily pleasurable, they don't bring joy, but they're kind of a necessary part of being functional, like grooming, dressing, cleaning, getting to events on time. And then pleasurable activities, where we're looking at the very hobbies and interests that people had that really brought them joy. It's probably not bringing them joy currently with their level of depression, but it's important to at least gradually reintroduce those activities so that they have an opportunity to perhaps even enjoy a moment of it. And then values driven, where we're looking at volunteering or taking new classes as examples, something that really lines up with a person's values of whether it's their education or self-fulfillment, or if they're trying to volunteer more to improve their commitment to the community. Things that are values driven are an important part of adding back into their life so that they feel like they have a purpose. It's a well-known, effective for treatment for depression and mood-related problems, and it does provide a chance to have a destigmatizing view of depression that is not solely because of thinking errors or because of a flawed way of thinking, but it allows us to implement a behavioral change, which hopefully will later help with some changes in their thoughts and their feelings. Why might this be a good fit for eating disorders? Well, significant comorbidity is one reason. Most individuals, as we've seen in the studies here and in other studies, that probably the majority of individuals with eating disorders have at least some level of depression. So if we treat only the eating disorder and their depression is lingering, very unlikely, in my experience anyway, that they're going to be able to maintain recovery from the eating disorder. This behavioral activation also addresses the overemphasis on body shape and weight, maybe not in a direct way, but indirectly by trying to really focus on what is a person's values, what are their pleasurable activities, and can we line up their life activities around that rather than being, around their body shape and their weight. It also helps in establishing a more moderated routine of exercise, similar because we are going to want people to introduce physical activity because it lines up with pleasure or with the value for them, not because it's a certain number of calories that are burned. Very delicate balance. It requires a lot of progressive, methodical work, but people can get there. Treatment steps are going to look very similar to what we just talked about with the exposure-based work, where there's an assessment. The patient or client is involved in a lot of the self-monitoring and creation of the plan, and then we're going to progress through that hierarchy in a pretty similar fashion. So similar in the assessment part is a methodical, try to be comprehensive, look at what are the avoidance patterns, what are the important activities you used to engage in, what are the values or things that you think will bring meaning to your life or used to bring meaning to your life, and then the current obstacles for that. The self-monitoring involves getting people involved in creating these, literally creating these maps that will help them see the patterns of avoidance that have been created in their life. This is gets a little bit involved, but I think you can see that's pretty similar to what we went through with the example of an individual who did not get a promotion at work. And when we have individuals map this out with us, they can see that the active coping response ends up having a much better outcome for them versus the avoidance pattern, which ends up leading typically to more depression. And so the self-monitoring occurs through their mapping out the track flow chart. It also involves activity monitoring of their own, looking at their hourly activity and their mood through something that looks a little bit like this, where we might take a typical day and hour by hour ask them to track what activity they were in and to rate their mood. This time we use a 0 to 10 scale, with 10 being the most depressed. So I think the important point here is that if you had someone in treatment who is depressed and you asked them if they thought they would enjoy reading a mystery novel because they used to enjoy reading mystery novels, if their depression is significant, they'll probably tell us no, they wouldn't enjoy that. They probably would not initiate that activity on their own. But if we instead had them map this out, they could see that laying in bed and isolating, they rated their depression as a 9. If they talked on the phone with a friend, it was a little better. If they showered and brushed their teeth, they weren't quite as depressed. And then if they read the mystery novel, they rated it as a 5. People can decide for themselves which activity might be worth trying to add. So rather than it being a power struggle, it's not their parents or it's not their significant other or their loved one, saying, get out of bed and do something today. It's a person making their own decision based on what they've mapped out in conjunction with the treatment providers. Similar to the exposure list, we're going to have people rank these lists of activities that we've identified are important to engage in again. And then we're going to gradually have them do more and more of these activities, starting with ones that feel most manageable. So this time, instead of them ranking the level of anxiety, it's simply ranking the anticipated difficulty. We're back to that 0 to 7 scale here. And so something like getting out of bed at 8:30, pretty low level of difficulty, but finishing up and sending in college applications probably ranks up there as being extremely difficult. The other thing that we ask individuals to then participate in here is determining what category this is in. Is this a routine kind of ADL activity? Is it a pleasurable activity, or is it something that lines up with our values? And then we work with them on trying to reintroduce these a little at a time, starting where it's manageable in terms of the anticipated difficulty, as well as the total volume of different things we're asking them to do. and we're just gradually adding more in, maybe every couple of days, as they feel like they've mastered the ability to do those things consistently. So again, both of those techniques are ones that I think, at least in my experience, have resonated with the men in our treatment programs, because, and partly because they're more active. There's a very cooperative stance to it. There's a feeling of doing, in addition to all of the other work that we do with the talking parts of psychotherapy. But there's much more doing involved in these two techniques. And in my experience, that has resonated with the men in our program very nicely. So do these techniques work? Well, we'll share with you some of the findings that we put together a couple of years ago, over about 2 years, or almost a 2-year period of time, looking at the men in the program with us, a variety of outcome measures that are used during the treatment process, but certainly upon admission and discharge. We typically are going to have individuals complete an eating disorder examination questionnaire, fear of food measure, body image avoidance questionnaire, body checking questionnaire, and the quick inventory of depressive symptomatology, otherwise known as the QIDS. And do we get good results? Well, we looked at different levels of care. Main thing I'll point out here, the age is pretty similar across here, the mean age, late 20s. Length of stay is an important consideration as we look through different levels of care. Inpatient, of course, is relatively short compared to the others, but it's 17 days here in this study. And then length of stay, about 53 days for residential, nearly 30 days in partial. And we'll look at, these different measures at different levels of care. This is the inpatient level of care where these techniques are employed there also. It's very active form of treatment, even at the inpatient level of care. So that there's a significant change, a clinically significant change in 3 of the subscales of the EDEQ. And then residential, we see statistical significance in all of the changes. And particularly, it stands out to me is the very low level of residual symptoms, especially in the restraint and eating concerns by the end of this. And then PHP also getting statistical significance in a number of the subscales, and then in the global score. Fear of food, showing significant changes across all 3 scales in the inpatient level. Residential, partial, didn't quite reach statistical significance on the food avoidance. And then body image, which is, as we know, is usually the last thing to get better. This is a very elusive kind of symptom or area of improvement. And I typically don't expect to see a substantial change in a short inpatient stay. Even in our partial programs, not always seeing a significant change there. But residential, the study here bears out what I experience anecdotally, where people really do a lot of work in these exposure-based techniques to look at body image and to come away with significant changes there. Body checking similarly. And very importantly, because of the comorbidity with depression, some of these measures here are going from moderate to severe levels of depression down to mild over the course of, in some cases 17 days, for inpatient, other cases a little less than 2 months, which is a long period of time. But I think when you look at depression studies in general, getting significant change in 6 weeks is pretty good. So I'll leave the case examples here for individuals to review, or we may end up in that category if there aren't significant questions. But I think at this stage, I'll probably move over to see if there are questions. But I again wanted to emphasize before we move into that, what we have exhibited here is a number of findings from studies across a number of different sources that give us some of the demographics related to men in eating disorder treatment, or men who are in need of eating disorder treatment. We've looked at some of the differences or unique features, and we've looked at I've shared some of the anecdotal experiences of a relatively large number of men in the treatment programs where I practice. And then we've seen some of the treatment techniques that are not specific for men, but seem, in my experience anyway, to resonate with men because of the more active component of being a part of the treatment process and being very much a hands-on and a doing, methodical approach. And then seeing some of the results that come out of those sort of behavioral therapy techniques being applied. And so with that, I think I will see if there were questions that we can address.
All right. Yeah. Thank you, Brad. What a great, thorough analysis and explanation of the population of men that you've been serving at Rogers. So thank you very much for sharing all of that. We do have a question from a listener who's asking about if you're aware of any research that focuses on men of color or diverse cultures. This person says NASAR's research seems to be limited to females of different cultures. Much of the other research this person has found focuses on BED with minority populations. So any insight or recommendations on resources for looking at men of color or diverse cultures?
I don't have anything off the top of my head on that because it's not an area that I think has been well represented in the research, but I'm happy to put together some work to see if we can find something.
Yeah, I think that's a point well taken, Brad. There's as you've tried to convey, and as we know, eating disorder treatment is not at all one size fits all, and it's so important to be sensitive to the very specific experiences that each person has had. So, so to the listener who asked that question, yeah, we can definitely follow up with you about that. And certainly we will have a couple other webinars coming up soon that are addressing the LGBTQ community and transgender populations, which, both of those populations were outside of the scope of this presentation. But again, the point is that there are so many unique experiences that we need to be very careful about how we're generalizing. And so, Brad, I really appreciate that you focused in on cisgender men for this particular presentation.
Thanks. And I feel like this is, a much bigger topic in terms of what we're just describing, that the continued progression and evolution in our eating disorder field requires a lot more research. Right. This is a little bit parenthetical or a little bit of digression, but I had worked in other fields in mental health for many years before coming to work more exclusively in eating disorder in populations. And I've always known that that mental health fields in general seem to be lagging in research compared to the rest of the medical field. And then I found when I came to the eating disorder field that there seemed to be even more of a lag or less robust of the academic literature in the eating disorder field. There are a variety of reasons probably underlying that, including a lot of academic. There's a lack of programs or interest in academic departments where a lot of research typically flows from. But when we look at some of these areas that are coming more to light now, different populations and subpopulations and how eating disorders might affect different people, we've got a long ways to go. And it's taken a long time for more information about cisgender males in this whole field, and it's still growing, but there's just a long way to go in terms of the research. So anything that any of us can do to continue to promote research and continue to promote good studies in this field and to give generously to foundations that are sponsoring research is going to go a long way.
Yeah, very well said. Definitely. We do have a couple questions coming in. Everyone who is still on the webinar, please note that we have posted the link to the post-webinar small group discussion. You're welcome to start heading over there pretty soon. But since we do have time, we'll get to these questions. Let's talk about the prevalence of trauma in men with eating disorders. Is this noteworthy? Any comments on that, and what are the effects of being bullied around weight for men?
A couple things rolled into that one. So
yeah, right, that's true.
So similar. I don't have the numbers off the top of my head for the co-occurring trauma and eating disorders for men. For women, it's fairly high, and so I again will do the research and get the numbers for the listeners, but I would imagine it's similar for men. So, and I think it is a very significant issue, as we see in all individuals with eating disorders. Men, are just like with a lot of vulnerable type topics, I find are less likely to bring that forward, are harder to reach in terms of trying to do the therapy around trauma. And so it can play a very significant role in this. And I think the second part of the question about the bullying, is another form of trauma that may not be considered as the meeting criteria for PTSD. So they may not formally get diagnosed with PTSD, but that's often been kind of one of those, hallmarks of the progression, or some of the early thoughts on what happens for men with eating disorders. Is the typical scenario has been, it's been someone who struggled with weight issues in their youth, got bullied from it, and then started to engage in unhealthy behaviors to try to affect change. And then the eating disorder got out of control. But the bullying has been a known component for the progression of eating disorders and image issues for boys and young men, certainly.
Yeah, absolutely. Very good. And then, all right, so then going to the other end of the age spectrum, any comments on men over the age of 55 and beyond?
Well, they're fewer and farther between. I'm not sure if the question is stemming from individuals who develop eating disorders in late ages, people who have had them all along, but we have certainly seen both varieties. Individuals who develop eating disorders very late in life, sometimes as a part of co-occurring mental health issue that has gotten out of control, or sometimes as and this isn't exclusive to men, but when we see eating disorders happening or starting late in life, it's oftentimes related to a medical issue, where someone has, lost the ability to eat regularly because of a medical condition, and then perhaps, liked the results or got favorable feedback about the results and in the changes in their body, and then sort of took over from there. So it's not common, but, for men over 55, we have seen that of individuals developing that. I would say if there's a theme there that I've seen in individuals in that age range, for men, it's been individuals who have been very active in some sort of sport or activity that had really emphasized body image or a certain body type. So, individuals who've been bodybuilders, wrestlers, some of the stereotypes of professions or endeavors that people do where weight is very much an important part of what they do. And the eating around it is very precise and nearly obsessional, that then when those activities are no longer, pursued at the professional or high leisure type level, that the person is left to continue a lot of those behaviors, and then it becomes more of an obsession in their later years. But there's no longer necessarily a reason to do it. You're not, not engaging in those activities anymore, but they're still employing some of those behaviors, and it gets out of control.
Yeah. Yeah, absolutely. Yeah, and it looks like we have someone listening today who is kind of nodding through the chat. He seems to relate to a lot of what you just said, and to that listener, I wish you the best with the relapse, and feel free to call our helpline if there's anything we can do to help. And of course, Brad, I think you would be a great resource as well. We'll be sure to share contact information and the slides following this presentation along with the recording if you're open to that. And I think we'll go ahead and close this out because it looks like everything else in the chat right now is some interesting commentary, but not necessarily questions. So so we'll go ahead and close this out. Again, maybe we can post the link to the post-webinar discussion group one more time so everyone has it at the bottom of the chat. And people can start heading that way. And I just want to give a very big thank you to Brad for this incredibly insightful and detailed presentation, to Rogers Behavioral Health for their very generous support of this webinar and our entire webinar series, and to all of our sponsors, and to all of you attendees who listened today. We're so grateful for your interest, and feel free to check out our website if you'd like to learn more about what we do. And yeah, we'll see you back here next week, Wednesday at 1 p.m. So thanks again, Brad.
Thank you, everyone. I really appreciate it.
Yeah, thank you.